Hello, Dr. John.
How you doing?
I'm good. How are you?
Busy.
Sorry to bother you.
No, you're not bothering me. Hold on. I just got to get these other.
Okay.
There we go. I'm just getting the other screens off.
All right.
Okay. How you doing, Mila? It's been a while.
Yes, it has. I've been doing good. Dr. John, I'd like to ask, can you send me like a background picture? Because I don't want to show this.
Yeah, okay. Yeah. Okay. Give me a second here. Okay, I got a lot of good backgrounds.
All right.
Let me show you.
Okay. You had given me a background before as well, but
Okay, can you see them?
yes.
That's the hallway of The Shining. You know that, right?
Yes, I do.
Oh man. How come it's not going forward? Okay. Here, let me pick out one. I'll send it. Okay.
Okay.
Great.
Or do you think this background is fine? Like,
No, hold on. I'll get one.
all right.
Yeah, I'm trying to share it. Okay. You see the picture? Can you copy that?
Um, I don't know how to
You see the
copy it.
picture, right? You see the picture,
Yes,
right?
I do see the picture.
Can you copy that?
I can try. 1 minute.
All right.
Okay, I'll see if I can crop it.
There, I could send you this. Oh, I know how to do it. Wait a minute. Let me go to your. Okay. Yeah, I got another way. Um, okay. Yeah, I got a better way.
Okay. Yeah, the one I have is a bit blurred.
Yeah, this may work better. Okay. Okay, I sent it to your WhatsApp. Oh, no, I didn't. Where's your WhatsApp? Okay.
Oh,
Hold
I've
on.
changed it. Can you
No,
see it?
no, I got it. Hold on. This is a better one, I think.
Okay.
Okay, it's on your WhatsApp now.
Okay.
That should be better.
All right, I'll check.
Yeah, that is very blurry. Is that the new one I sent?
I'm just changing it at the
Okay.
minute. Please give me a
Yeah,
minute.
that's the old one.
Yeah. Background.
Still the same, huh? Yeah,
Uh,
that's terrible. That's terrible. You can't
no,
use
no,
that.
no. Check now. Okay. How about now?
No,
I've
no.
changed it. No?
So, yeah. Okay, that's what happens when you wait till the last minute. Okay, get another image or do
How
what you
about
want.
this?
That's fine. That's
All
fine.
right. That's great.
Okay. Yeah, we won't have many people. That's okay.
Some people are still joining, so I'm just like messaging them.
Okay. Threaten them. Threaten them. Say you kill their dog if they don't come. You poison their dog if they don't come. What do you think?
That's a good idea.
Oh, no, oh, I'm sorry. We're live now. We shouldn't do that.
Oh, are we live?
Yeah. I edit after right away. Take off the front part.
Okay.
Mm.
We have some Russian speakers as well from my university. So, they don't really understand English a lot, so I might be like translating here and there in case they have any questions.
Hold on. I'll be with you in a second.
Okay.
Did you need a password to get in? You needed, what's that you
Oh, in the
needed?
beginning I did, but not right now. Dr. John, can you admit another attendee? I'm not able
Yeah,
to.
yeah, okay. And I'll give you rights to do that too.
All right, thank you.
It looks like a Russian person.
Yes, she's from my university.
Should I say something? Good
Okay.
night.
Oh, welcome. Привет, как дела?
Хорошо, все, спасибо большое. Thank you so much for that lecture. I was waiting for that.
No problem. We're just waiting for some people, and inshallah, I can start in like 6 minutes, hopefully.
Okay. Oh, wait. Okay. I'll disconnect the mic so I won't bother anyone.
No problem.
Okay.
Trying to make you panelist. I don't know what's going on here.
Oh,
Trying to make you like a co-person, you know what I mean?
I do.
Co-panelist.
Co-host, I think.
Okay, just tell me when. Let's try something. I'm going to put basically that it's live and wait a few minutes. You know what I mean? Because
All right.
I'm just basically getting it out. Maybe I'm saying it's live now. Maybe I'll go to Instagram. Do you use Instagram very much?
I used to, not at the moment, or except if I'm like
Do you
wanting
use
to watch.
Instagram very much?
I do, like, but like sometimes, Dr. John, not always. Dr. John, we can start in like a minute.
Okay. Let me just post it on Instagram and we'll go.
Sure, no problem. I'm not sure where our people are from, like the WhatsApp group I made. Dr. Gordon, Dr. Allah, they all wanted to attend, so I'm not really
Okay.
sure.
Okay. Uh, um,
Dr. John, can you please make me panelist? We have some
yeah,
more.
okay. Very good. We have a couple of people that they don't want to come in.
It's all right.
It's okay. Well, whatever. They can participate. They can ask questions. Okay, ready to start? We'll add people as we go along.
All right.
Just give me 1 second here. Wow. And you are in Russia now, right?
No, I'm currently in Saudi Arabia. I came home for holidays,
Oh
but
my God. Okay, so you're in Saudi, but you go to you're a student in Russia, right?
yes. Yes.
And you're originally from Turkey, right?
Oh, it's okay, Dr. John. You don't need to mention
No, no.
that.
Where are you from? Where are you from originally? Saudi's your home.
Yes, this is my home.
Okay. No, I'm not trying to make you Turkish.
It's fine.
I'm trying to change your citizenship online.
Even Turkey is all right, Dr. John.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting for Neurosurgical TV. I don't have my banner up. I should. I'll put it up later. For pleasure to have the honor of hosting Dr. Mala Mangi, originally from Saudi. She's in Saudi at home for the vacation, and she's going to school in Russia. She's a multicultural girl. Okay, okay, Mila, it's all yours.
Thank you so much, Dr. John. Good morning, good afternoon, good evening, good night to everyone. I'm sure everyone is in different places around the world. I'm Dr. Mila Mangi, as Dr. John introduced me, and today we're going to be starting a series of revision for the USMLE. Since neurosurgery is my domain, I'm going to be covering the neurosurgical or neurological aspects for the USMLE. So, let me get into it. I'd also like to welcome some people who are from Russia, and I had some people texting me from Pakistan as well. So, привет, как дела все? Сегодня я говорю об этом, об USMLE шаг один. If anyone has any questions, you can always send them in the chat or you can like text me, but I'll only be able to reply once the lecture's over. Okay, so without wasting any time, I'm going to share my screen. Okay. Sure. Can you guys see my screen?
Yes, trees.
Yes.
Okay.
All right. So these are my handwritten comprised notes, which I was using when I was preparing for the step one. So this is like the famous textbook. And as always, in this textbook, there are a few quotes. My favorite one being Stephen Hawking's quote, which is basically, we are all connected by the internet, like neurons in a giant brain. So it's always fun to like start your studies with something that's going to like give you motivation as well as encouragement, because the USMLE is a difficult exam. It's not easy, and I'm sure everyone needs motivation from time to time. Okay, so let's start with the embryology. So basically, this structure is the neural development, as you can see on my screen. What you have to remember is exactly what the notochord is. It induces overlying ectoderm to differentiate into neuroectoderm and form the neural plate. The USMLE doesn't really give you very basic questions from the embryology, but if you know your basics, you can solve any question. All right. So the most important thing here that you have to understand is what the notochord becomes. So it becomes the nucleus pulposus of intervertebral discs in adults. And the other thing that you have to like know is what the lateral walls do. Like what are the lateral walls divided into? So they're divided into alar and basal plates. The alar plate is also called the dorsal plate, which is sensory. Please do not forget that. That's very important. And it is induced by these types of proteins. They're actually called bone morphogenetic proteins, the BMPs. The basal plate is ventral, and since the alar plate is sensory, the basal plate is motor. Also, a very important point that someone should remember. And this is induced by the sonic hedgehog. Now, moving on to the famous diagram of the neural tube. This you have to memorize. There's no other way around it. Some people make mnemonics. I wouldn't really advise that. I just learned it as the diagram mentioned in the textbook. So first you have your forebrain, which is also called the prosencephalon. Then we have the midbrain, which is called the mesencephalon. And last but not least, we have the hindbrain, which is called rhombencephalon. So the forebrain is divided into two parts, the telencephalon and the diencephalon. The telencephalon goes on to form the walls. Which part of the walls? The cerebral hemispheres, the basal ganglia. And then the diencephalon goes on to form the thalamus and hypothalamus, also the retina. Moving towards the mesencephalon, midbrain, which forms the cerebral aqueduct. Now, you should remember how the CSF is formed and through which walls it travels through, okay? So this is sometimes like a question anyone can ask you, and it's not really that simple in the USMLE exams, but like as long as you know your basics, you can solve anything related to medicine. Uh, okay, next, the metencephalon forms pons and cerebellum, which go on to form the upper part of the fourth ventricle. Last but not least, it's the myelencephalon, which forms the medulla, and this forms the lower part of the fourth ventricle. So this is a famous diagram. You have to learn it. There's no other way around it. Central and peripheral nervous system origins. Now, in medicine, I'm sure everyone has learned the CNS neurons, CNS glial cells. We've got different types. We've got astrocytes, oligodendrocytes, and ependymal cells. Now, the neurocrest is formed by the PNS neurons, which basically are like, dorsal root ganglia, autonomic ganglia divided into sympathetic, parasympathetic, enteric systems. And then we have the PNS glial cells, which are formed, for example, by the Schwann cells, satellite cells. And the mesoderm, this you have to remember, microglia, like macrophage. Now, like in this textbook, there are a few mnemonics that can help students to like memorize the word. So like M, mesoderm, medulla. Oh, sorry, microglia. So, it's like it's easy to remember. Moving on to the neural tube defects. So, we have a few of them which are very important. The first one being the spina bifida occulta, which is a closed neural tube defect. It's the only one which is closed. The rest, which are meningocele, myelomeningocele, and myeloschisis. All three of them are open neural tube defects. Again, you have to memorize them. There's no other way around it. Now, anencephaly. It is also an open neural tube defect. The failure of rostral neuropore to close. There is no forebrain in these types of patients. And mostly patients present in hospitals or in clinics with polyhydramnios. In the diagram, like, it's just to show you exactly how it looks like. Normal, you can see like the skin, the dural layers, the leptomeninges, like it looks normal. And then moving on towards the myelomeningocele, it's a completely abnormal picture, very easy to understand. Brain malformations. Now, there are some things that you have to remember. The first one being holoprosencephaly. So basically, what this is, it is when the forebrain fails to divide into two cerebral hemispheres. And this occurs between 3 to 4 weeks of development. Mostly, it can be seen in Patau syndrome, which is trisomy 13. Okay, don't get confused. Genetics is really important, and everything in medicine is correlated. So some conditions you have to remember relate to other conditions. For example, if you have a picture or a question regarding Patau syndrome, you should automatically know that it can cause a brain malformation. All right, so these are just some things that you can use to remember. How do they present with in clinics? They present with midline defects. For example, fused basal ganglia or a cleft lip, cleft palate. And this increases the risk for pituitary dysfunction, for example, diabetes insipidus. I have also mentioned a few notes, which you can see. There's a defect in migration, and where the tick is, it's basically eyelids are partially fused, blind-ended, middle of the face. So these are like some of my own notes, which I wrote just to like remember things. Moving on towards the next brain malformation, it's the lysencephaly. What happens here? Failure of neuronal migration. Smooth brain surface lacks two important things, the gyri and the sulci. Okay. It presents with dysphagia, difficulty in swallowing, seizures, microcephaly, and facial anomalies. All right, moving towards the next part, posterior fossa malformations. There are two very important conditions, Chiari malformation 1 and Chiari malformation 2. When I was doing my exam, I think I had a question regarding Chiari malformation 2. Very simple, very basic, nothing out of medicine. Let's discuss it. So, Chiari malformation 1. It's downward displacement of the cerebral tonsils through the foramen magnum. It's usually asymptomatic in childhood, manifests in adulthood with headaches and cerebellar symptoms. It's associated with syringomyelia. Very simple, very easy to understand. Next, Chiari malformation 2. It's downward displacement of the cerebellum, which includes the vermis and the tonsils. So key highlights are it's the cerebellum and the medulla, two structures, whereas Chiari malformation 1 is just one structure, cerebellar tonsils. This is also through the foramen magnum. It leads to non-communicating hydrocephalus. This is more severe, hence regarding the number 2. And how does it present with? Difficulty in swallowing. In medicine, it's called dysphagia, stridor, apnea, limb weakness. This is associated with myelomeningocele. Again, there are two differences that you should remember. Carry malformation 1, it's associated with syringomelia, and carry malformation 2, it's associated with myelomeningeal. Next condition is one of my favorite conditions, Dandy-Walker malformation. Now, this is when the entire cerebellar vermis, there is agenesis of it, cystic enlargement of the fourth ventricle. Now, if you look carefully, you can see there is a cystic enlargement of the fourth ventricle, the arrow in B, that fills the enlarged posterior fossa. This is associated with spina bifida or non-communicating hydrocephalus. Moving towards the next condition, syringomyelia. What is this exactly? As you can see in the MRI shown in A, it's a fluid-filled gliosis-lined cavity within spinal cord. There are yellow arrows clearly indicating it. And what is damaged first is the spinothalamic tract, and it forms, like, according to textbook language, cape-like loss of pain and temperature sensation in bilateral upper extremities. As lesion expands, it may damage the anterior horns, and what happens if the anterior horns are damaged? We get lower motor neuron deficits. The most important thing you have to remember here is it occurs between C2 and T9. Also associated with carry malformation 1, as I just previously mentioned. Moving on towards the anatomy and physiology. So right now we just covered our embryology. Few conditions that you can go through, try to understand them in depth. And of course, if you have time while preparing for your USMLE Step 1, you can even go and try free question banks or even buy subscriptions just to help you clear your concepts. Okay, anatomy and physiology. Cells of the nervous system. We have 4 types of glial cells: astrocytes, oligodendrocytes, ependymal cells, and the microglia. I'm not going to read them in great detail, but we can just discuss them just to give you the general idea. Astrocytes, they're the largest and most abundant glial cells in the whole CNS. Anything that occurs, gliosis happens in response to any injury that occurs with astrocytes. Next, oligodendrocytes. This mostly shows a fried egg appearance. Very easy to understand, very easy to identify. Whenever you get MRI images, you cannot get confused with this condition. These types of cells are injured in multiple sclerosis. Something that you have to remember. It can come up in exams. Moving towards the ependymal cells. Now these produce CSF. Microglia. They are not readily discernible by Nissl stain. Regarding stains in microbiology, you don't have to memorize each and every type of stain, but it's just good to know which type of stains are used in daily life. So this is just for your own general knowledge. Moving on towards the PNS. PNS glial cells. There are 2 types, the satellite cells and Schwann cells. These do come up as basic questions in Step 1, so do not ignore them. Satellite cells. Now, satellite cells, they surround the neuronal cell bodies in ganglia. Schwann cells, however, they're myelinate axons in the PNS. You have to remember this, that they are S100 positive. Sometimes it can come up, sometimes it can't. Each myelinates a single axon. These types of cells are injured in GBS, another very famous condition that always comes up, so you have to read it in great depth. Let's move towards the neuron action potential. With action potentials, I'm sure that you've studied this, when you were studying pharmacology and basic medicine. Everyone knows how the action potential curves looks like. You have the resting potential, And then when the sodium channels activate, they reach the threshold potential, and then the potassium channels open and potassium flows outwards, and we go back to the membrane hyperpolarization and back to the resting potential. Pretty simple, straightforward. You cannot get confused here. Okay, next thing, sensory receptors. We have a few receptors that you have to memorize. Please give me 1 minute. I'm just taking out a picture. All right, moving on. We have free nerve endings. What do these free nerve endings do? They sense pain and temperature. They're present everywhere except in cartilage and islands. Basic common sense. I mean, you can't really get confused with this. What you have to remember is A delta plane is fast, but a taxi is slow. This is another mnemonic. Next, the Meninges corpuscles. Now, these are present in hairless skin. What do they detect? They detect fine or light touch, low frequency vibration, and skin indentation. Moving towards the Pacinian corpuscles. These adapt very quickly, just like the other corpuscles, but these detect high frequency vibration and pressure. Merkel discs, they are present on your fingertips. So if you can remember like what's present in your like extremities, you cannot get confused when answering questions. Last but not least, Ruffini corpuscles. These sense not only stretch but also joint angle changes. I personally haven't seen a question which tests these sensory receptors, but you never know. It's always good to like know which cells detect which things. I mean, they can always come up. Moving towards the peripheral nerve. This diagram is very famous. Mostly examiners use it to test students. As you can see, there's a nerve fiber surrounded by the endoneurium, which is surrounded by the perineum. There's an epineurium. It forms the nerve trunk. This type of cells, they can be affected in GBS. The blood nerve permeability, perineum, P permeability, it's easy to remember. And the epineurium, this is a dense connective tissue that surrounds the entire nerve. Epi, like epidermis, something like that to easily remember. Moving towards neuronal response to axonal injury. So we have a process for axonal injury. Number one, what happens? There's dispersion of Nissl substance. This is called chromatolysis. Basically, the Nissl substance, it disperses through the cytoplasm, which you cannot really visualize on a stain. Neuronal cell bodies reaction reflecting increasing protein synthesis. As you know, these are cells and they also have protein synthesis, protein translation, everything occurring at the basic level. Once the nerve is injured, the protein synthesis is also affected. They're accompanied by round cellular swelling and displacement of nucleus to the periphery. Next, the axonal reaction. Proximal axon segment retracts and sprouts new protrusions that grow toward other neurons for potential re-innervation. In the PNS, the Schwann cells create a tract that guides axonal regeneration. So, it's just good to visualize exactly what's happening on the basic level. Next, Wallerian degeneration. Now, this does come up not only in step 1, but it's also a step 2 question. Distal axon segment and associated myelin sheath disintegrates with macrophages removing debris. I got a lot of questions from students asking why do we need to know everything about macrophages? See, macrophages are not only used in tuberculosis. They're not only the main cells involved in initiating like an immune response. They're also used in removing debris in Wallerian degeneration. Many students do forget this, so do remember this. Moving towards the neurotransmitter changes with disease. Now, this table is very important. As you can see, we have the most important neurotransmitters. For example, acetylcholine, dopamine, GABA, norepi, and serotonin. I got a question asking me the location of serotonin. So don't forget that it's located in the raphe nucleus of the brainstem. And this table basically tells you which neurotransmitter increases or decreases in which condition. For example, in Alzheimer's, you have acetylcholine decreasing. And in Huntington's disease, you have acetylcholine decreasing with GABA, but dopamine increases. So it's just good to remember the most important conditions. Parkinson's is another favorite. Acetylcholine increases, but dopamine and serotonin decrease. Something that you should remember. Next, Meninges. We have a lot of questions with Meninges. Since we just discussed embryology, it's easy for you to understand the meninges of the brain. 3 membranes that surround and protect the brain and spinal cord. So there are 3, the dura mater, the arachnoid, and the pia. The dura is the thick outer layer closest to the skull. Arachnoid layer, it's the middle layer, contains web-like connections. And the last is called pia mater, which is thin. So key differences, pia is the thin layer, whereas dura is the thicker layer. Why is it so important to memorize these meninges? Well, basically it's because of CSF. CSF flows in the arachnoid space, in the subarachnoid space located between arachnoid and the pia mater. The epidural space, it's a potential space between dura mater and the skull. The site of blood collection, it is associated with a very special artery. It's the middle meningeal artery. If there's damage, blood collects into the epidural space. Moving towards the blood-brain barrier. This prevents circulating blood substances from entering the CSF. Common sense, if anything enters the CSF, we can have serious problems to the brain. And that's why we have the barrier protecting the brain. It's formed by 4 structures. Number 1, the tight junctions. Number 2, the basement membrane. Number 3, pericytes. And number 4, astrocyte foot processes. 2 important types of components, they can cross the blood-brain barrier. Glucose and amino acids. Most people think that because glucose is such a heavy molecule, it might not be able to cross. Actually, that's wrong. Glucose and both amino acids, they cross slowly through carrier-mediated transport mechanisms. Nonpolar or lipid-soluble membrane substances cross rapidly via the process of diffusion. Something that you should remember. We have a condition, vasogenic edema. So what basically is vasogenic edema? It's when the blood-brain barrier is disrupted, for example, in a stroke. We have some agents, for example, mannitol. It's a hyperosmolar agent which can disrupt the blood-brain barrier. And once the blood-brain barrier is disrupted, this increases permeability of medications, which can be very harmful to the body. Vomiting center. Now, the vomiting center is the area postrema. This is coordinated by the NTS in the medulla. Now, this diagram is also very important because it shows you exactly what occurs, where it occurs. For example, if you look at the bottom, you can see the nucleus tractus solitarius and which types are included in it. We can just read through it because I think this is actually important as I've made a note of it myself. Now, we have histamine, H1, muscarinic receptor, M1, the neurokinin, NK1, dopamine, D2, and serotonin. 5 HT3. So for the GI, serotonin is acting there. H1 and M1 antagonists, they treat motion sickness. H1, however, treats hyperemesis gravidum, which occurs in pregnancy. Chemoreceptor trigger zones, there are three hormones affecting that: dopamine, serotonin, and neurokinin. So for myself, I thought of a mnemonic just to help me remember: DSN. You are free to think of your own mnemonics to help yourself. Moving towards the sleep psychology, the sleep physiology. Sleep is a very important topic. Many students skip this and then end up regretting it when they find questions on the USMLE that they have to solve. So, sleep occurs in 4 to 6 cycles per night, each lasting approximately 90 minutes and consists of two main stages: the non-REM sleep and the REM sleep. The REM sleep is sleeping throughout the night. Sleep-wake cycle is regulated by the circadian rhythm, which is driven by the nucleus of the hypothalamus. Exactly which one is the SCN, suprachiasmatic nucleus. Low light conditions decrease the activity of the SCN, and which further increases norepi to release from the superior cervical ganglion, thereby increasing melatonin from the pineal gland. Now, here in this textbook, this diagram is drawn so clearly that you can never even forget it. If you look at the awake stage of total sleep, this is where the patient's eyes are open. And in open eyes, we have beta waves, which have the highest frequency but the lowest amplitude. There's no other way to memorize this. You are free to think of your own mnemonic, but me personally, I just read it a couple of times. I tried to memorize it as it is because this does come. Eyes open, awake patient, beta waves, highest frequency, lowest amplitude. And when the patient's eyes are closed, alpha waves. Now, non-REM sleep is divided into 3 stages: stage N1, stage N2, and stage N3. Now, N1 is 5%, which is light sleep and theta waves. Stage N2 is 45%, deeper sleep, and there are 2 important components that you have to remember. We have something called K complexes and sleep spindles. Now, if you look carefully at the diagram, you can see the sleep spindles are like shorter horizontal lines, whereas the K complex basically looks like an ECG gone wrong. You can see there's no P wave here, except the ST segment is there and it's really rapid, as if it's third heart block, for example. And when teeth grinding occurs, teeth grinding in medicine, it's called bruxism. This occurs in stage N2 sleep. So if you have a patient coming to you and complaining that his partner is grinding in his sleep and they're trying to figure out what's wrong with him, try to think about sleep patterns, because teeth grinding occurs in stage N2 of non-REM sleep. Moving towards the deepest non-REM sleep, which occurs in stage N3, which is 25%. Now, this is slow wave sleep. Delta waves are occurring here, lowest frequency and highest amplitude, totally opposite of beta waves, okay? Now, they may serve in memory processing function. It's not yet proven. The most important thing to remember about stage N3 sleep, it's that when bedwetting, sleepwalking, and night terrors occur. So 3 important things you have to remember: bedwetting, sleepwalking, and night terrors. They occur in stage N3, 25% of non-REM sleep. Last but not least, it's REM sleep, 25% again. Here, there's loss of motor tone and increasing brain oxygen use. When dreaming, nightmares and penile/clitoral tumescence occurs. Remember, dreams in REM and night terrors, bedwetting, sleepwalking, that's stage N3 of non-REM sleep. So you can get MCQs with these conditions. They do seem fairly easy, but because a USMLE uses like different language, you might get confused. So it's better to like go through the text once or twice just to familiarize yourself with all the concepts. Now, what factors do we have affecting sleep architecture? There are a few important things. We've got alcohol, benzos, barbiturates, which decrease N3 and REM sleep. Now, benzos are useful for sleepwalking and night terrors. Normal aging decreases N3 and REM sleep. They increase the sleep onset latency and early morning awakening. So, as the patient ages, they can come to you and complain about early morning awakening, but this is not a complaint in medical terms, as we have just read that in old age, they have early morning awakening. Depression decreases N3 sleep, increasing REM sleep and decreasing REM latency. And we have a condition called terminal insomnia. Again, early morning awakening, terminal insomnia. Narcolepsy decreases REM latency. So I know these things might be a little confusing, especially with the latencies and everything, but if you read them once or twice, you'll be able to understand them better. Moving towards the hypothalamus. Basically, the hypothalamus maintains homeostasis by regulating thirst and water balance, controlling the adenohypophysis, which is basically a fancy word for the anterior pituitary. And the posterior pituitary is called the neurohypophysis. They release hormones produced in the hypothalamus and regulating hunger, autonomic nervous system, temperature, and sexual urges. So, in this textbook, there's a mnemonic tan hats, which you can use to remember it. The inputs, areas not protected by the blood-brain barrier, OVLT, sense changes in osmolarity, area postrema, vomiting center, found in dorsal medulla, response to emetics. So this is basically just a general description of the hypothalamus and its functions. Moving towards the lateral nucleus, this regulates hunger. This is stimulated by the hormone ghrelin and is inhibited by the hormone leptin. So the hormone that makes you hungry, this is ghrelin. And the hormone that gives you like satisfaction once you've eaten, it's leptin. So do remember this, it's an important question. If there's any lateral injury, it makes you lean. Another mnemonic that you can use. Something fancy, it depends on person to person. Some students like using fancy mnemonics while others just stick to basics. Moving towards the ventromedial nucleus, this controls the satisfaction. For example, when you're satisfied with eating or you've had a nice meal and you feel good, this is stimulated by the hormone leptin. Ventromedial injury makes you very massive. Another crazy mnemonic. Anterior nucleus, this controls cooling through the parasympathetic, like AC, anterior cooling. Posterior nucleus is the opposite, so it's heating and is sympathetic. The suprachiasmatic nucleus, this circulates the circadian rhythm. Supraoptic and paraventricular nuclei circulate or synthesize the ADH and oxytocin. So ADH and oxytocin are carried by neurophysians down axons to the posterior pituitary, where these hormones are stored and released. Some students forget that these hormones are not only stored but released, so do remember this important point. Lastly, the preoptic nucleus. This is actually used to control thermoregulation and sexual behavior. It also regulates a very important hormone called the GnRH, growth hormone releasing. Okay, the GnRH, if there's a failure of the GnRH producing neurons to migrate from the olfactory pit, you have a condition called Kalman syndrome. Please feel free to read about the Kalman syndrome because it does show up not only for the step 1, but in step 2 as well. Thalamus. This is a major relay for all ascending sensory information except olfactions. So we've got the ventral posterior lateral nucleus, we've got the ventral posterior medial nucleus, lateral geniculate nucleus, medial geniculate nucleus, and lastly but not least, ventral anterior and ventral lateral nuclei. I'm not going to go through them in great depth because these questions don't really come up as it is in this chart, but it's just good to read for your own knowledge. Like you should know it. You should be able to answer questions about it. So we're gonna stop right here with my notes. I'd like to now show you some of the questions from UWorld, just to like give you an idea of how questions can appear and how you should like prepare yourself to be able to answer them. So let me just minimize this. All right. Don't get scared yet. This is just the first question. Does anyone from the chat want to try to read this with me, try to solve this with me? Anyone?
I'm being with you mentally, but I
Sure.
want to try. Yeah, I'm here with you. I'm supporting you.
Okay, great. Let's start with question 1. So there's a 19-year-old man. He's brought to the ER after sustaining a traumatic brain injury during a motor vehicle collision. On arrival, the patient is comatose and has a Glasgow Coma Scale. You can also just call it the GCS score of 3. It's very low. His blood pressure is 110 by 70 and his pulse is 114 per minute. So his blood pressure is a bit low. Normal is 120 by 80. This patient's is 110 by 70. And his pulse is 114 per minute, which is very high. The pupils are myotic, equal, and reactive to light. Ecchymosis is present behind the ear, but the remainder of the trauma survey is unremarkable. Rapid sequence intubation is performed and the patient is mechanically ventilated. A non-contrast head CT scan demonstrates bifrontal contusions and a basilar skull fracture. Now, you have to remember in the fracture of the base of the skull, you have something called the battle sign. So battle sign is basically when there is tenderness and the patient can have bleeding per nose or per mouth, and you can see it on the mastoid bone. All right. 1 day later, a repeat head CT scan reveals diffuse cerebral edema. The ventilator respiratory rate is adjusted to achieve a PaCO2 level of 26 to 30 millimeters Hg. Which of the following is the most likely of this intervention? So, we have 5 options. We can just go through them one by one. Decreased brain metabolic demand, increased cerebral perfusion, increased cerebral blood volume, increased cerebral vascular resistance, and increased displacement of the CSF into the thecal sac. Now, if you look at this question generally, I know for a fact that option E is wrong. Like the thecal sac, it has no business with our question. This is how you have to solve a question, like minimize all your options, getting to the right answer. Now you've got 4 options. If you look at the explanation, they've given you 2 graphs. One is a hypercapnic vasodilation. The other one is a hypoxic vasodilation. You can see that the CSF in hypercapnic, it's like it goes up, and then there's an equilibrium. The equilibrium is at 75. Whereas in hypoxic vasodilation, it decreases around 50 and then it reaches an equilibrium. So if you think about this, the PaCO2 is 26 to 30, which is a bit low. The brain has little room for expansion as it is encased in the cranium. A small volume change in any of the intracranial components, for example, brain tissue, blood, CSF, can produce significant changes in the ICP. Therefore, even small increases in the cerebral blood volume can raise ICP and cause brain compression. So here when systolic blood pressure is 60 to 140, it has little effect. Blood pressure, when it increases more than 150 mm per mercury, this increases cerebral vascular volume and blood flow, causing a compounding increase in the ICP. In contrast, blood pressure, which is less than 50 mm per mercury, this causes cerebral hyperperfusion and potential ischemia. This question is not very difficult because 52% of people got it right. And if you go through the options like decreased metabolic demand, that seems incorrect. You're left with three options: increased cerebral perfusion, increased cerebral blood volume, and increasing cerebral vascular resistance. Cerebral vascular resistance is the correct answer. Because when you think about it logically, and after reading the explanation, you know that this makes sense. I mean, it's not something that you can get confused with. I didn't take a screenshot of all the other options because I don't really think they're all necessary. When you go through the course and when you practice a lot of questions, you'll be able to see a pattern, and then it's easy to identify your weak areas and compare them with your strong. So this was question 1. Question number 2. This is a very famous diagram. You have to memorize it as it is. There's no other way around it, and you will always get a lot of questions on it. So this is very important. A 56-year-old woman is brought to the ER with sudden onset of headache and partial loss of vision. She has a 3-year history of atrial fibrillation. Physical examination shows intact motor function and a visual field defect involving the black areas illustrated below. Now, this question is basically remember and match a sort of question. If you can look at the right side of the screen, you can see that there are letters A to H mentioned, and each one of them stands for a specific component. For example, A, this is monoocular scotoma. B is right anopia. Now, if you look at the question, this is clearly posterior cerebral. The patient most likely has an occlusion of the posterior cerebral arteries. This question is not you have to go through it in depth or something. No, this is basically memorize and apply. Memorize and apply. Something to give you a challenge. Think of this as a challenge. Moving on to question number 3, I think. A 40-year-old woman enrolls in a clinical trial. The patient has had persistent discomfort in her lower extremities for the past 2 years. She describes an uncomfortable sensation in her legs, particularly in the evening and at night, but there's no pain. The symptoms are relieved with leg movement or walking. She has experienced no behavioral or mood changes. The patient intermittently experiences mild migraines, and during a recent episode she found that antiemetic therapy worsened the leg discomfort. Vital signs are normal, and physical examination shows no abnormalities. Blood cell counts, serum chemistry studies, and serum iron levels are within normal limits. Treatment with a novel agent, an alpha-2 delta calcium channel ligand, is initiated. The patient receives significant symptom relief with this therapy. This novel agent used in this trial is most similar to which of the following medications? Now, this question might seem really difficult at first, really challenging, and you might feel lost. But don't panic. Read the question again and highlight the most important thing, being leg discomfort. Okay, so when the patient has lower extremity discomfort, can't move their legs properly, and it worsens at night, this is a very important condition called restless leg syndrome. There are some things that you just have to memorize. One being that restless leg syndrome, this is mostly it happens in iron deficiency anemia. And patients later on can develop Parkinson's disease. So this is just something that you have to memorize. There's no other way around it. Once we've discussed that, symptoms are relieved with movement and are typically worse at night, according to the explanation. There are certain medications which can be used. Like I just mentioned, iron deficiency is related to restless leg syndrome. So, we have some things that we can advise the patients or we can administer. Dopamine antagonists, certain antiemetics, for example, the most famous one, metoclopramide, first generation antihistamines, diphenhydramine being the most famous, and antidepressants, for example, like the SSRIs, like sertraline, mirtazapine, they're also associated with worsening symptoms. Now, that is choice E. Choice E is like, it's not like the best option, but it's also one of the options. Treatment includes lifestyle changes, lifestyle measures, for example, limiting alcohol and caffeine, and of course, alpha 2 delta calcium channel ligands, for example, gabapentin and pregabalin. Now, this question is basically like testing if you know which of these drugs work at which receptors. So it's very straightforward. Gabapentin works at alpha 2 delta calcium channel ligand. So this is just something that you should memorize. Moving towards the next question. A 37-year-old man comes to the office due to difficulty sleeping. He says that his new job as a business executive is very stressful and requires considerable travel. During the past 3 months, the patient has made numerous trips between the US and France. He frequently experiences insomnia and daytime sleepiness for several days after he travels, but his sleep improves significantly thereafter. Which of the following hypothalamic nuclei is most likely responsible for this patient's symptoms? Now, as you just saw my presentation, you should understand that I have just discussed the major functions of the hypothalamic nuclei. This is basically like a copy paste of what we just read. If you know the nuclei and their functions, you can easily solve this question. Some students, they use tricks to remember it, mnemonics or whatever. For me, I personally like writing things down and, like repeating them because repetition helps you to quickly answer questions, as you do know that every block of the exam, you have an hour and 40 questions. So you don't really have a lot of time to sit there and make notes and then solve the question. This is basically, learn it and apply it. Here, basically, the patient is experiencing difficulty sleeping due to jet lag. He's traveling from the US to France, so there's significant jet lag. And which hypothalamic nuclei is responsible? That's the suprachiasmatic, which regulates the circadian rhythm regulation and the pineal gland function. Moving towards the next question. Now, this is one of my favorite questions because only 64 people have gotten it correct. A 27-year-old woman comes to the office due to severe unilateral throbbing headaches. When you see the sentence severe unilateral throbbing headache, it's migraine. Close your eyes, it's migraine. That occurs several times a month. The headaches are associated with photophobia, nausea, occasional vomiting. Over-the-counter analgesics do not provide significant symptom relief. Her mother has a history of similar headaches. So you can think of this as it's also genetically affected. Vital signs are within normal limits. Physical examination reveals no abnormality. So there's no papilledema, there's no ICPs, there's no hemorrhages, there's no trauma. A medication is prescribed to treat her condition, and the patient is instructed to take it immediately at the onset of a headache. This medication most likely decreases the severity and duration of the patient's headache through which of the following mechanisms? Now, this is a memorizing question. There's no other way around it. You have to understand that migraines are always stimulated when the trigeminal vascular serotonin receptors are stimulated. So this is like memorizing question. There's no other way to like understand it. In the U world explanation, they'll give you these graphs and like these like showing you how it works, vasodilation and everything, but this doesn't answer our question. So for these types of questions, you have to like memorize basic knowledge to be able to like answer this question. I personally don't really know why they included this picture, like it has absolutely nothing to do with the explanations, but yeah, this is your world. Moving towards my favorite question. A 17-year-old right-handed boy is brought to the ER due to brief loss of consciousness. So there is brief loss of consciousness after colliding with another player during a football game. So there's trauma. The patient reports fogginess but has no headache, no vomiting, no focal weakness, or no numbness, or no seizures. He has no other medical conditions and takes no medications. Vital signs are within normal. On physical examination, the patient demonstrates retrograde amnesia about the game, but no focal neurological deficits. CT angiography of the head reveals no skull fractures or intracranial bleeding, but a small lesion in the left temporoparietal parietal region composed of abnormal vascular channels is noted and is shown in the exhibit. I did not take a picture of the exhibit in the question, but you can like see it on the right side. So this is basically what was shown. Without treatment of this abnormality, which of the following will occur in this patient? So this is basically like one of those questions where they give you a picture and you just have to identify the condition. Not very dangerous, not very difficult. A brain abscess has a specific picture. Flaccid paralysis has a specific picture. So does malignant transformation and spontaneous resolution. Now, this specific diagram is very, very important and it's very easy as well. As you can see, there's arteriovenous malformation. A famous word, like 3 words to remember, it's called bag of worms. Every time you see this specific picture, just know that there are like the arteries, like the vessels, they're like shaped like a bag of worms, like how the worms are like moving. And this is a typical picture for spontaneous hemorrhage. So this is like, identify and apply. Moving on towards the next question. Another one of my favorite questions, which is also basically memorize and apply. A 62-year-old man comes to the office with left arm clumsiness. Physical examination reveals motor weakness involving the left arm and leg. So this is on the same side. Ipsilateral, left arm and left leg. The patient's speech is slurred and there's drooping of the left lower face. On passive flexion of the left arm, there is initial resistance followed by sudden release of tension as flexion is continued. A lesion affecting which of the following brain structures is most likely responsible for this patient's condition? So, they've given you a diagram, and there are like 5 letters mentioned: A, B, C, and D, and E, and you have to like identify it, and you have to identify it correctly to be able to move on to the next question. So basically, A is the caudate nucleus, B is internal capsule, C is putamen, D is globus pallidus, and E is insula. You have to be able to identify this, and the only way you can do that is if you have studied basic knowledge and studied diagrams thoroughly. The reason why I got this question right is because I have had extensive practice in like drawing pictures, just like drawing rough diagrams in my notes and, trying to label them. So this is like really easy if you have had a lot of practice. This patient specifically has a clasp knife spasticity. And this is seen with upper motor neuron lesions, which are mostly caused with injury to the internal capsule. So internal capsule is B. that's how I was able to answer this question. Next question. Let me see. We'll do this last question, and then we can move on to something else. A 54-year-old man is brought to the office by his daughter. She says that her father has been acting strangely over the past 2 years. He makes inappropriate sexual jokes, has little regard for social rules, is often irritable, and is borderline aggressive at times. The patient denies that his personality is any different than normal. So the patient himself doesn't really feel that there's anything wrong with him. When speaking with the patient, the physician notices that he has minimal vertebral output and repeats, "It is what it is." When asked questions about his strange behavior, I swear, some of these questions in the USMLE, they just make you laugh. On physical examination, it appears unkempt, but otherwise has no significant findings. The patient most likely has a condition that predominantly involves which of the following structures? Now, again, this is a memorize and apply type of question. The patient is making sexual jokes, is very irritable, acting strangely, doesn't really think there's anything wrong with him. So the condition basically here is frontotemporal dementia. Early personality changes, there's apathy, disinhibition, and compulsive behavior, frontotemporal atrophy on neuroimaging. And basically, the answer is anterior temporal and prefrontal cortices. You should, however, know your other conditions like on your fingertips: Alzheimer's disease, vascular dementia, NPH, which stands for normal pressure hydrocephalus, dementia with Lewy bodies, and prion disease. So this is all for today. You might be wondering why I have taken pictures from the U World. Actually, I had a subscription for it, but it's expiring soon, and since we cannot download it, I've just taken a few pictures of it. What I would like to share with you is that if you want to practice questions, you can use this app called LabRange. This app right here. Of course, it's paid through a Russian person and in rubles. But if you do need help, like me or anyone else can help you. This is like much cheaper than like buying another online resource. However, LabRange has only specific NBMEs which you can try. The most important ones being 27, 28, 29, 30, and 31. The rest are fairly old, and I don't recommend anyone doing them. Let me just show you how the app works. So like there's a username, there's a password, once you've paid for it. I think I paid around like 4,000 rubles for it, and it's like a 1 year subscription. So like the agent that you're buying through is going to give you a username and a password. You log in and you just can practice as many questions you want. There's an option for you to check the difficulty. There's an option for you to check how many questions you want to do. Does anyone have any questions?
Well, I do have a lot of questions actually, but I think we're
Sure,
not.
go ahead.
Yeah, got in the time if it's possible.
Mhm.
I'm gonna text you maybe if it's all right.
Sure, no problem.
You have your camera working today?
You asking me, Professor?
Yeah, you can put your camera on.
Right now, I wasn't like ready to put my
Oh,
camera.
okay, that's no problem. Okay.
Okay. Thank you so much for lecture.
No problem. I hope everyone understood it, and I hope you're able to like better prepare for the USMLE.
It's quite a task. It's not getting easier, huh?
Yep.
Yeah.
If someone like dedicates like let's say a minimum of 6 months, it is doable. The exam is doable. But yeah, 6 months of dedicated study period.
I can tell you from personal experience, if you work hard, you do well, period. There's no two ways about it. You can't avoid the work and the memorization. But it's very, like you say, it's very doable. Just like anything else you do in neurosurgery. If you work hard at it, usually you can figure it out.
Yep, that's true.
That's not a revelation. That's just basically fact that you learn through your career. I really, because I had associates that took courses to prepare it, and it helped them a lot. I had a friend, he actually did better than me because
Oh, wow.
he took a Kaplan course. Do you guys still have Kaplan courses that
Yes.
prepare you?
Yes, we do. But
It
Dr.
was,
John, I didn't take any courses. I just like studied on my own, and I went through like the app which I just mentioned, LabRange. I did my NBMEs. I took the free 120, and that's it. That's all I did.
yeah, I know Kaplan used to be very, very good, and it helped him a lot. And he's an orthopedic resident now. He wasn't really a good student, but he took that course and really applied himself. I'm sure there are different courses now.
Yes,
You guys, you kids have so much to access. You know, there's so much. You just have to pick something. But usually you pick something that approved by a friend that's done it. Because yeah, you don't want to waste too much time
yep.
uh, with programs that aren't good. Anyways, okay, very good. So okay, we'll work on the attendance. Now, what we need to do, I find that the best conferences are run by people that prepare well. That people, and the formula is to get panelists, to get
Yes.
people, friends of yours, that can kind of support you and they also give input and things like that. The panelists are key. Otherwise, it happens like today. You know, nobody asks questions, which is fine. Which is fine, but
Maybe it's like the first day and people are like nervous. I
yeah, it's
completely.
okay. You'll get over it and find out that you learn more when you participate. That's no golden secret.
Yep.
And I know that Mila is going to learn the subject well teaching it. I mean, you learn it better. And I'm sure she can attest that she learns much more when she has to prepare for these because she obviously has to become acquainted with the material. She has favorite questions, so she's going to recognize that lesion in the internal capsule right away, right away, right?
Yep. You're
And you
right.
wouldn't have learned something like that without studying. It's not magic until Elon Musk makes a chip for things like brain pathology. But until you get that chip, we gotta study.
Yep, that's true. I personally agree. I'm actually planning to give the step two, inshallah. So I've heard like people who get like 270s and 280s, like everyone who gets a high score always tells me that the base has to be really strong, and the base is step one. So my goal is to like practice, practice, practice so that I can like, get that score which I really want to get into the specialty I really want. So this is just revision, revision, revision. And yeah, I
Okay,
agree with you.
okay, keep the course. Okay, anybody have any comments? I'd like to meet some people. Does anybody wanna meet us or say hi? You don't
Dr.
have to.
Yusuf
You
is
don't have
here.
to. That's okay. Who's here?
Dr. Yusuf, Nehemiah, and Disa. Disa is here. Yeah.
Would you like to? You don't have to introduce yourself, but you have the opportunity to say hello. If not, we'll just move on and wait till next week. Or maybe I'll meet you next week. Okay, then. Thank you very much, Marla, and thank all the panelists, all
Thank you
the
so much,
attendees for
Dr.
coming.
John.
We'll see you
Thank you.
later. Bye-bye.
Bye.
Bye.